Great. So I'm now going to turn the program over to Pam Russell, Danielle Culp, and Tim Cortez. Pamela Russell is the Long-Term Care Program Director with the Government Programs at COREO, the Colorado Regional Health Information Organization, and she's currently managing the TEFT grant for HCPF. Tim Cortez works for the Colorado Department of Healthcare Policy and Financing as the manager of the Community Options section, and Danielle Culp is the Quality Health Improvement Specialist over at HCPF. Thank you all for joining us.
Thank you.
Thank you.
Okay. Hello, so this is Tim Cortez, and if we could go to the next slide, please. So I wanted to start with the mission of healthcare policy and financing, and our mission is to improving healthcare access and outcomes for the people we serve while demonstrating sound stewardship of financial resources. Next slide, please. Oh, one too far. Oh, or we're missing one.
Before domain. Oh.
Oh, it's actually we're missing a particular slide. I do want to. So let me just touch a little bit on outcomes specifically, since it's called out in our mission. I think when we have the presentation online, we'll actually be able to include that particular slide. But I do want to talk about outcomes specifically because I think one of the things that, I think will help provide some context to TEFT as well as to also make some distinction between long-term care and healthcare and some of the different emphasis and values that long-term care has as compared to the healthcare system in general, or at least the different focus areas. And the four domains that we've specifically talked about when we really want to think about the client holistically is clinical outcomes, functional outcomes, outcomes related to quality of life, and utilization outcomes. Now, typically in the traditional healthcare environment, particularly when we talk about health information technology and like medical homework, what tends to be the emphasis is on clinical and utilization outcomes, and healthcare typically focuses on curative treatment versus what I would say is improving functional status or improving quality of life. Now, in long-term care, we tend to focus mostly on functional care, or functional outcomes, as well as quality of life outcomes. We're not trying to cure a disease as much as trying to maintain someone's independence or prevent them from functional decline, or at least delaying that functional decline over time. And so a lot of our service and supports are really geared towards maintaining the client's functional status as well as improving their quality of life. And so we tend to assess functional deficits and functional, status with our clients a lot. And there's a lot of that data that's in the long-term care system that typically isn't shared with clinicians and people in the healthcare setting. But one thing to keep in mind about all of these outcomes, whether we're talking clinical, functional outcomes, utilization outcomes, or quality of life, is that there's interplay between all of these functions, or all of these outcomes. And so if a client starts declining functionally, particularly if they're declining rapidly, that might be the indication of some adverse medical event that's occurring, or it could be because of a medication management issue. And vice versa, if we start seeing sharp declines in clinical outcomes, there's going to be a corresponding decline in functional outcomes. And so the idea of thinking of clients in this context of not just in clinical and utilization outcomes, but also thinking of the functional outcomes and quality of life is a really important thing to keep in mind. And as we start talking about working with long-term care clients and we start going into the different components of TEFT, this is going to become much more important to keep in mind because from a client's perspective, what they're going to be mostly focused on is their quality of life and their functional status, and that has much more impact than what their like A1C levels are because they're seeing the functional outcomes and quality of life play out in their real lives, and while their blood sugar levels might be invisible to them or not as apparent. So let's go ahead and move on to the next slide, and let's talk about the TEFT components. And, you're already there, actually, because we don't have the other slide. With the TEFT components, there are really four core parts to the TEFT grant. And the thing to keep in mind with the TEFT grant is it's trying to create standards in long-term care that previously have been either, I would say, haven't been there hasn't been standardization across the industry in long-term care across these different components that we're going to talk about. And so the TEFT grant is specifically looking at creating these standards in long-term care that have kind of remained undeveloped. I think this is where, in some cases, the healthcare system has moved a lot faster in terms of standardizing certain standards of care, whereas the long-term care system is still playing catch-up, particularly around the probably what I would say are assessment areas and using health information technology. So the four components that you see, you'll see that as it's in a puzzle piece, and there's a reason for that, because essentially we're trying to create this puzzle around long-term care, or pull pieces together, and all of these pieces are interrelated, and it creates, and you see kind of a master plan coming together when you put these pieces together, so the idea is that with the TEFT components, as they develop, that there will be they'll feed into each of the other components, and there will be sharing of information across these different initiatives. So one particular component is the patient survey about their experience of care and services. This is a quality of life survey, and I will have Danielle Culp speak to that particular component.
Thanks, Tim. So CMS saw the need for an experience of care survey specifically aimed at assessing the HCBS programs, and is primarily funding the development of this new cross-disability tool to align with the Agency for Healthcare Research and Quality, AHRQ, and also to align with the Consumer Assessment of Healthcare Providers and Systems, which is the CAPS project. In doing so, they've identified the CAPS as being a family of surveys assessing a person's experience with a variety of healthcare settings and services. So in order to make this a more standardized tool, we have first implemented this in the field just this last year, and we're hoping that the results of this will ultimately allow us to become a CAPS certified tool, which would then provide us a standard methodology for benchmarking the performance of our healthcare providers using the data obtained from this survey, specifically the voice of these recipients or clients based on their experience of care with their HCBS services. Recently we received the final results from this survey. We have not received any reporting or any specific data analysis. As I mentioned, this first year and pilot was just to obtain that CAP certification. So we have just completed, and Colorado is currently at 88.13% completion, which is pretty good in comparison to some of the other states. We did have 100% completion in, let me go back one step. We actually utilized two different waiver populations for this survey. Our first waiver being the EBD, Elderly, Blind, and Disabled waiver, and we also utilized the Supported Living Services waiver. And in doing so, we encountered some barriers in that with our EBD waiver population, we were able to complete at a full 100%, whereas with our SLS waiver, which includes the ID-DD population, we were only able to complete 52.5% of our in-person surveys. By phone, we were able to complete 100%. So we were expected to complete 80% of our surveys in person and 20% by phone. So just to clarify that, we were only able to complete the 52%, and we've identified the main reason behind that is that we were not allowed to use proxies in this first round. So that's something that we're discussing with CMS and hoping that we can modify for our next round so that we're able to capture more of the client's perspectives in their experience of care and help inform us on how we can further identify those needs and gaps within the system. Also, we would like to, as an ultimate goal, is to use the survey as a tool so that we can be better informed on how to develop really great quality measures to measure the quality of services at that specific program level, and also to enable the federal and state government to expand quality improvement efforts. beyond just program specifics, but to encompass individual quality of life and outcome measures across populations. So this is really a cross-disability tool, and it's the first of its kind to be implemented here in Colorado. We're really excited about it, and we are just excited to start with round 2 in 2016 for the survey.
So this is Tim Cortez again. So as Danielle mentioned, the Experience of Care survey is really a survey around the client's quality of life and their experience of care. And so, if just to tie this back again to the previous discussion that I guess information I was providing related to outcomes. So this is directly related to the quality of life outcomes that I had talked about in the previous slide. So the Experience of Care is really about that component and trying to make sure that we can assess the impact that we're having on clients' quality of life through our services and supports that we offer. So the other piece that that's part of the TEFT component is the Continuity Assessment Record and Evaluation Tool. The acronym for that is the CARE tool. This is an assessment tool that's typically used has been typically used in post-acute care, particularly looking at transitions from hospital settings to long-term care settings, whether that's community care or if it's care in a nursing facility. And so it tends to focus more on so there is some medical information that's included in that assessment, but the majority of the assessment tool is really focused on, as a functional assessment tool, and really focuses on trying to identify functional deficits and needs for clients, so that the I guess facility or agency that's going to be providing care can then make sure that they're providing the services to address those functional deficits or needs that are identified through the assessment. So Colorado will be part of this pilot. The pilot, so the CARE tool is already I would say been evaluated and determined as a reliable tool for post-acute settings. So CMS is actually trying to now expand it into community settings for just all long-term care settings, not just post-acute. And so they're going to be adding some additional items to the CARE assessment for us to test and to look at how we can actually do functional assessments within people's homes, regardless of whether they came from a hospital or if they're just trying to access long-term care for the first time from their home versus having to go through a hospital discharge to access that. And so there's going to be some additional items that they're going to add, and we'll be testing those. This is also part of a larger long-term care assessment pilot that we're doing in Colorado, because there are and so the CARE tool will be one of probably a handful of modules that we'll develop that actually try to help us become more person-centered in our approach to assessments, as well as to designing person-centered plans for clients. And so the CARE tool is just one of many pieces that we'll be looking at over the next year to try to develop a more person-centered approach to assessments in the long-term care world. The other component that's with the TEFT is, and what the bulk of the conversation today will be about, is specifically the personal health record and rolling out and piloting a personal health record in long-term care settings. This would be particularly community-based settings. And so this has never been done in Colorado, and as far as we know, that there's 8 states participating in this particular pilot. And there's not been a standard set for long-term care, and it's typically a lot of PHRs have really been extensions of I would say EHRs, or electronic health records. But because this is now looking at community-based long-term care settings, it's going to have a different flavor, I would say, and a different approach to the way that we've traditionally rolled out personal health records. And so we're going to spend a lot of time talking about that today. And so those are the 4 components. And again, I think they all relate back to the outcomes that I had talked about before, because the idea of the PHR is that we're pulling together clinical data with utilization data, with quality of life and the assessment data together in a personal health record, and making that accessible to a client so that they can make then informed decisions about their services and supports, as well as, I guess, their life. So let's go ahead and go to the next slide, please. So this is a high-level timeline for the TEFT grant. Now, I'll point out that the CARE tool, which is the assessment tool, and the experience of care survey is actually on a different timeline. This is mostly the timeline. This describes actually at a high level the timeline for the personal health record. And we'll go into more detail about each of these phases later on in the presentation. This last year, we spent a lot of time just planning what we're going to do. And so we actually had a planning grant from CMS to actually figure out what are our next steps and how do we implement a pilot for all of these different components that we talked about. And we've divided the personal health record, pilot into 3 different phases. And there's going to be a phase 1 in 2015, a phase 2 in 2016, and a phase 3 in 2017. And we'll, as I said, we'll go into more detail of each of those phases later on. But this at least gives you a snapshot of our approach and kind of a high-level breakout of the different phases. So I'm going to turn it over to Pam Russell, and she's going to take it from here.
Thank you, Tim. Yes, we are very excited about this grant. It was actually written back in 2012, I believe it was, whatever. And so the idea with a personal health record in the long-term support services arena, we were very excited here at Carrillo, especially with the work that I've done in the long-term care with many of the long-term care providers out there. So we started out with understanding from a statewide effort, so like keep it real local. We went statewide. The TEFT partnerships on a national level included, of course, Center for Medicare and Medicaid and ONC, which is the Office of the National Coordinator for Health Information Technology, which is why we call it ONC. And the contractors were Truven Analytics, the Lewin Group, and Research Triangle, RTI. The grantees, like it shows there, 9 states. We're down to 8. I think New Hampshire is not in. The state partnerships, we started out with stakeholder meetings across the state. Actually, last June, July, reaching out to the Medicaid providers, the HCBS providers, the RICOs, the ACOs, the community-centered boards that work with the IDDD populations and SLS, and when we went out for these stakeholder meetings, it did include Danielle Culp as well as HICPUF to be able to go out and meet with everyone. Like we said before, the 2 focus waiver populations were the elderly, blind, disabled, and the supported living services. So it was quite challenging because PHRs, personal health records, are not widely used by everyone across the country, let alone a population as challenging as this. We're up for the challenge. And what's going to help us is having all those partnerships and stakeholder meetings across the state. We also are very, very fortunate to have some state partnerships. And I put Civic there. It wasn't just Alpha. But Civic has been awesome because of the Healthy Transitions work that Kristen has done. So Civic, Telegen, which is formerly CFMC, Quality Health Network, our HIE on the Western Slope, the Colorado Department of Human Services, Aging Adult Services that have all the Area Agency on Aging, the Colorado Health Foundation, Colorado Healthcare Foundation. It's all on your slides. But we were so fortunate to have state partners that also were very interested in what could be done in the long-term support services in a person-centered approach through a PHR. Some of our key achievements that were done during the planning phase was, like Danielle commented, we completed round 1 of the Experience of Care survey. We had sent out surveys actually last July 1st, and basically to a lot of the providers and different agency groups that I mentioned, just to kind of get a feel. Where are you at? Do you have an EMR? Do you have an EHR? Do you know what an HIE is? Have you ever heard of a PHR? I mean, basically trying to get a feel of where people are at in health information technology. It helped us as we then held our stakeholder meetings to know who would come and what kind of questions they would have. Another key achievement, though, was to create some criteria for PHR vendors, which absolutely came out of our stakeholder meetings. When we talked about our stakeholder meetings, who came, we had a lot of case managers. We did not actually have the true elderly, blind, and disabled patients or the developmentally disabled clients actually there in person, but we had their case managers, their care coordinators, like I said, the RICOs and the ACOs, the Primrose Place Assisted Living, the Senior Resource Center, the non-medical home health providers, and we had key people who actually are working to keep the long-term support services clients in their homes with services that they need. So and as we kept meeting, different ideas kept coming out about what would be what would you want to see in a PHR. We referred to it as the solutions for PHR partnerships, but it must be able to integrate data coming from a health information exchange. If we wanted to have both clinical and non-clinical data in a PHR, then it's important that the data is at least attached. Health information exchange, could be whatever source. We also said it must be able to take data input from a client, a caregiver, or a provider in the form of other devices. So if they're inputting in their own laptop or their iPad or something, we want to be able to say, how can we also take different data input so that there's not multiple sources to put the same information in. We talked about it must be customizable. You see the non-clinical and the clinical. They want to be able to display benefits and waiver-related information. And absolutely what came out in every single stakeholder meeting was it's got to be secure. Well, is it in the cloud? Who's going to watch it? What's your security issues? We then also talk about what about alerts? So let's say I'm the provider and I want to know if someone does go to the ED, be able to have some alerts just to have some idea of what's going on in a quicker period of time as opposed to having time delay. So that was our solutions that actually I will say that was kind of stolen by everyone else, I think, in the other 8 states. CMS, Juvenile Analytics, they love this. They actually have these solutions up on their website because it was able to put it in one. And from that, we also, learned some lessons learned from our planning phase. We want to be able to facilitate stronger communication in round 2 of the EOC and talk about having other people helping actually with this survey. We also want to, going statewide was challenging, but we do see that we are able to see trending and patterns with clients and long-term support services. Long-term support services just aren't in Denver. They are in Sterling and they are in Burlington and they're on the Western Slope. So we will stick with that. That we wanted to go wide, and that we know we need to kind of go from slow to go fast. One of the first meetings that we had, and I put out, we're going to start some other meetings, but I said sometimes it takes like 3 different meetings to really understand what is this grant all about. And again, as we keep kind of repeating it, the whole idea is that from Center for Medicare, CMS, they know that health information technology, it's left the station. That train is rolling. They gave incentive dollars, so to speak, to hospitals and physicians under what's called meaningful use. For those of us in long-term care, not so much. We did not, the funding was not there yet. We know that everyone wants to be able to get more technological and be able and not be so paper-based and not have so many multiple systems to input the same amount of information. So that's what the TEFT is really about. And when we started our community meetings, we held them from July through December of 2014. We actually held 11 on-site meetings across the state and 3 webinars. And again, the attendees included many of you on the call today, as well as the single entry points, like I said, the RICOs, the HCS providers, state partners, all of the different community-centered boards, which have been just awesome and supportive. And what do our stakeholders want? Again, when I talk about if you don't kind of roll something out that someone's going to use, we all have apps on our phones and this and that that we don't really use. We've got to be able to give a product, let's call it, that someone's actually going to use. We don't want to impede someone's workflow. If you as the case manager care coordinator as a RICO is already inputting something, well, we want to be able to look at your workflow, see how this could help, and be able to see how can we get all this information in one place to make it easier. So when the stakeholders, and we kind of said, well, what would you see in a PHR? This clinical, non-clinical absolutely kept rising to the top. The non-clinical, and again, we talk about a person-centered approach. They talked about their personal story. If you're a spinal cord injured, you've got, Parkinson's, you have, Fragile X. You don't want to go to get your assessment every year to your doctor and say, it changes. Like repeating your personal story over and over and over again. For many people, that's very difficult. For MS clients, Parkinson's, to be able to say, oh, when did your symptoms start, and have to repeat that. No, they want to be able to say, I need to be functional every day. I want to stay home. I want services. I don't want to keep repeating the personal story. So So non-clinical is a personal story. Staff schedules, meaning, when does the homemaker come? When does the, Meals on Wheels show up? Who's my transportation? Just some scheduling. Tracking their units, the units of service that they get. Again, they talked about alerts as well as having their support plan and goals, and we call that our non-clinical. And our clinical side, we certainly talked about medications, allergies, labs, RAD, physician visits, and also, again, talking about pushing alerts for ED. So when we got into the clinical side, that's where we kind of got into the technical, and that's where Creo and QHN come in. We're very fortunate here in Colorado. I say that all the time, but we do have two very, very strong health information exchanges. Combined, I think we have 95% of all the hospitals in Colorado are connected to an HIE. Hospitals and labs are what we call hospital centers, and then the receivers are like the long-term support services groups, the home health agencies, the hospices, the skilled nursing homes, the physician offices. They're the data receivers. So how a query-based HIE works, the Acuity Health Record, that Creo kind of cloud there in the middle, and then it shows who is feeding into it. And currently, what is from the hospitals, the public health departments, the laboratories, some radiology, is what's being pushed into, we call it being pushed into the HIE, which means all of our data receivers who are connected to the HIE, then that's what they can access. Our future includes our connection with CDPHE, Colorado Department of Public Health and Environment. So immunizations, public health alerts, newborn screening results, reportable conditions, all that we want to be able to be fed into the HIE. We get asked every day, when are you doing medication lists? When's medication reconciliation coming? We know that's a key component everyone wants, as well as having the ability to have diagnostic quality medical images right in the HIE. So if it's a physician for a home health patient, to be able to have that information access through the HIE on a 24/7 basis from wherever they're at is an incredible way, as opposed to saying, send them back to the ED and repeat something, as opposed to having all that. Orders is a big one. Everybody asks us. We know we want it. And the next slide. We must be reading minds, Kristen. So the next slide is QHN's, called the Perfect State of HIE. Same way. They have the cloud, the patient summaries in there. What they have feeding in right now are same thing, the hospitals, the labs. And then their bubble on the top is called some of their future ideas, too, is integration of behavioral health and the full integration of public health. So both of the HIEs having there was great. So as we kept talking about what a PHR, and you go to the next slide, the key considerations, and as I said before, what kept coming out was the security of the information. How are we keeping it secure? And we explain over and over how secure the HIEs are. The other was user flexibility, meaning, if an elderly, blind, disabled, how would a blind person access a PHR? How would somebody with issues with like MS or Parkinson's, how would they be able? So user flexibility is a big key consideration we're looking at as we move forward to PHR. The opt-out features, who do they want? And this kind of goes to funny word, but it's called granular consent. But it could be that the client, the beneficiary, they may want, their physician maybe to have this, but they may not want someone else not have it. So it's a personal health record. They determine who's going to have access to the PHR. So they can decide who they want to see their information. But the whole goal is designed to aid the client in managing their long-term support services. Next slide. I'll make sure I don't stay here. I'm trying not to talk too fast. And so what this means for implementation, of course, is that as we look at the multiple solutions, and we know that no one size fits all, we have to be able to do this implementation in multiple phases. And it's got to be meaningful for client-provider support, and we have to be able, when we talk about our measures of success, we want to address the success in each phase of the implementation. So let's go to the implementation. We put it in 3 phases, or you could even look at 3 years. So navigation is really our phase 1, year 2. But really teach how to navigate the PHR. Our whole idea from the stakeholder groups, we then identified what we call focus groups. Our focus groups are going to help us identify the pilot sites. We need the actual LTSS clients accessing the PHR. We need them to actually use it, touch it, feel it, say, what do you think? Is it easy, hard? Really, I wish it did this. I wish it did that. So teaching how to navigate the PHR is actually a key component of our whole navigation phase, year 2. in phase 2, the data feeds. Then we start adding some of the data, which is the PHRs connected to state HIEs, or maybe if a certain RICO ACO has an EMR, EHR, talk about also integrating with them. And then the last would be the dynamic phase, which actually really means where the client is actually starting to enter the data, and it becomes interactive, where their personal story can go, and they start tracking their own wellness and interact themselves with their PHR. Those are the phases. We then, as you all know, with any kind of grant management, you've got to be able to measure your success. So we want to measure our success of the TEFT grant in the PHR is, number one, its frequency of use. Who is using it and how often? There's no sense going to a lot of work if no one's going to use it. So the frequency of use is a key measure of our success. The next one is the efficient coordination of services. We're really able to track the scheduled appointments and units, and that's where it totally ties in with all the work HCPF is doing with all of theirs, to be able to say, how can we coordinate all these services? And last but not least is quality. We got to increase, the quality in services. Did this patient engagement really impact services? Did it impact their quality? We want to be able to certainly give them something that they can use that actually they're able to use, but also it has some impact on their whole quality. So we talk about the key milestones. We identified the 5 communities. God love it, I do have a Colorado map, but we did go north, south, east, west, and Metro Denver. And again, it was kind of that statewide approach, but we have identified the 5 communities in the state. We have demoed some electronic personal health records, both actually at some of our meetings and actually with a couple of the providers. We've looked at MonaHealth, Get Real Health, and FEI systems. We've also developed the State Partner Advisory Committee. That's what I talked about, the state partners. We met in December. My hope is then to do it, quarterly, not to overwhelm people, but again, give us some, as an advisory committee, give us some background and some feedback on how they think we're moving along, and then developing a partnership with the HCPF IT department to design an MMIS PHR solution. Upcoming challenges, again, as we went out, we learned this, the HCBS providers are at different levels. Some they've gone out and purchased their own EHRs, EMRs. Some are mainly papers. So everyone's at different levels, and that's a challenge. The case manager and care coordinators also maybe have a homegrown system or purchased something. And accessibility is huge. How do you assess, the internet? Do you have a laptop? Do you have a computer at, varying levels? And again, we got to have it usable across the board for those that are in the disabled populations. So next steps, focus groups begin March 20th. This is March 20th, 2015. So, and many of you on the call, if you've not, I've reached out to you. In March, we're going to do webinars to kind of give you a little bit of extra what I've talked about today, kind of a grants update. It's been a little bit of glitches as it is with grants, a couple months delay until CMS, and we have to wait for all that to happen. So the focus groups webinars start in March. We'll have the on-site starting in April. And from there, the focus groups will help us identify pilot sites, and we want to start the demos. And again, those are the next steps. So when we talk about working with HCPF and the new MMIS system, I'm going to turn this over to Tim Cortez to give us an update on HCPF and what's going on over there in IT. So next slide, I think, if you want.
So the slide you're looking at is really busy, but the idea of it is to show kind of the vision that HCPF has in terms of how we want the things to be connected, I guess, with our new systems that are going to probably come online in 2016, and then there'll probably be some additional system upgrades over the next years post-2016. But we are currently in the process of actually reprocuring our MMIS system, and with enhanced federal match by the federal government, we actually can cover the federal government will cover 90% of our new systems, and this includes not only just claims systems to manage claims, but it's also can support investments in our care management software systems, as well as other systems that are help us manage, the services, as well as help us support clients. And so there is the capability for us to look at creating portals for providers, portals for clients. Case managers would have access to a brand new system, and then there will also still be that financial management side of the system. So the arrows really indicate data flows, and that's the and the blue represents what is, I would say, within the Medicaid system. And so all of the blue bubbles and boxes are really talking to the HCPF systems that we would put in place to manage services and supports and as well as benefits within HCPF, as well as manage Medicaid enrollees, enrollments and services. And then you'll see there's an orange bubble in there, and that's a client-facing portal or a provider-facing portal, so that clients and providers can then access information or pull it from our systems, and they can kind of see kind of what their status is related to eligibility, as well as what services they've accessed and what potential services have been approved if they haven't used any services yet, if they need to get prior authorized and such. So that's the expectation with those. Now, the green boxes represent the health information exchange, and that's why we're working with Carrillo. So we have Carrillo, and we have on the western slope the Quality Health Network. But the idea is that at some point, Medicaid data will be pushed out to the health information exchanges, so that then it can be populate electronic health records, or that providers can then access through the health information exchange certain data elements from the HCPF systems. And you'll see that one of the bubbles that's attached to the health HIE or the health information exchanges are personal health records, and you'll specifically see one that's called out for LTSS PHR. Now, so what we are particularly hopeful at long range is that whenever we piloted this personal health record for long-term service and supports, is that it exists outside of Medicaid, so that it becomes a tool that anyone needing long-term service and supports could access and use, and that's why it's connected to the health information exchanges and not to HCPF, and it's not in a blue box. Is that because we want this to be more of a global record that people can have access to, and if they happen to have Medicaid, then through that personal health record, we can actually HCPF can push the data out to the HIE, and through the HIE, then it can populate the personal health record information that will be existing again outside of the HCPF system. So I think that kind of talks about our vision and our hope with this, with our new information technology that HCPF is hoping to put in place, as well as our linkage to the health information exchange and ultimately the information that will be available to the PHR to clients. So I think that's all of our presentation, and we'll open up for questions.
All right, great. Thank you so much. Just a reminder to everybody on the call, please feel free to enter your questions in the chat box, and then we can address them here on the webinar. As folks are freezing their questions and getting those into the chat box, I've got a couple questions myself that I will ask. And I think you started to touch on this a little bit, Tim, but ultimately, if this is successful, what's the potential impacted population? Who's going to be impacted by the success of this grant?
So we're specifically targeting community-based long-term service and supports clients. And so those are people with disabilities, older adults, people with developmental disabilities, people with brain injuries, people with who are blind. So we're hoping, and that they're eligible for Medicaid. I guess through the TEFT grant, that's who we would target. Long range, I hope that we can, if they're not Medicaid eligible, as I said earlier, is that the PHR would be a tool that's available to anyone who's trying to access long-term care, regardless of whether they're Medicaid or not. So I guess that would be the population that we're specifically targeting, are those clients that are living in the community and needing to access long-term care.
Great. So we have one question coming in from Vicki Linden. Will care coordinators and facility staff be trained to navigate the PHR so that they can help the member navigate?
Thank you. Great question, Vicki. And this is exactly what, when we start with our focus groups and we start with the pilot sites, when we talk about who is going to use the PHR, we actually say it's the clients and their caregivers, and the providers, which is the case managers and the care coordinators. We do feel that just from what the verbiage that we got back, that absolutely you do an amazing job of managing and submitting all the paperwork. So there is a correct number of units of service for all the clients and the patients that you take care of. So absolutely, we want you to be part of this and be involved in that. And so you would not only be watching the demos of the different PHRs, but then also when the training comes up too, yes, you will be trained.
Great, thanks, Pam. And that actually leads into another question I had, which was, if this is successful, both just in the TEFT grant and in the long term, what is the experience of care going to look like for someone accessing LTSS? How is that going to change?
Oh, I can speak to that.
Go ahead.
And I'll refer back to a particular slide that was talked about earlier, and that's what our stakeholders want, and it had the non-clinical versus the clinical slide. So right now, a client that is in receiving long-term service and supports, it's typically a mystery to them around eligibility and processes, particularly with the Medicaid system, because to access long-term service and supports is actually a lot more complicated than a non-client who doesn't need long-term care, because there's some different eligibility criteria, and it requires not only that they be financially eligible, but they have to be functionally eligible. So when we talk about that functional assessment that I mentioned, the CARE tool, we have to determine that a client is actually functionally eligible for long-term service supports, meaning that they have a need that needs to be addressed by our Medicaid supports. So typically that's a mystery to the clients about where they are in that process right now, because they have to go through two different agencies to actually get the financial part done as well as the functional assessment done. So the PHR would help in terms of helping them stay on top of their eligibility status and where they are in the process, and we are hoping that we can communicate that through the personal health record. The other piece, and I think the more compelling piece, is once they're in the system, one of the key domains of quality of life that we try to impact through our service and supports is choice and control of the clients. The more choice and control that a client has over their lives, and they're not feeling like they're patients, not feeling like they're clients, but that they're being supported in terms of managing their independence and living in the community successfully, and we're delivering those services with a light touch. The more choice and control they have, the better quality of life that they have, because they're not having to constantly focus on just their disease or their disability and such, because they have the supports that can make them live full lives. So that's why it's very important for them to be able to tell their personal story one time, and that story then can be shared through the PHR with other providers. If the client provides access to that personal story by giving the provider direct access to the PHR, or if they're able to push that story out to the different providers, then they can make known their preferences and how they would like to receive services. Because the services we deliver are very personal services. We're talking about supporting people with their toileting. We're talking about supporting people with their bathing, and so having to describe that every time to a different provider is a very intrusive conversation. The other piece that they really don't have control over right now that we could give them control over is being able to manage their budgets. Every person with long-term care actually gets an annual amount of dollars that they can spend, and they can't exceed that amount. And so it would be helpful for them to be able to track how much care they've actually used during the course of the year, and then be able to then adjust services and supports, or talk to their case manager to say, I either need more or I'm not using as much. Can I maybe use those dollars for another purpose? And so it gives them a little bit more control over their services and ability to track how much they've actually used during the course of a year, so that they can make adjustments as they need to. And then for them, just knowing when staff are actually going to show up is very important, because we're sending in people into their homes that provide direct services, either through personal care, homemaking services, meal preparation, or we're setting up transportation for them to get to their physician's office or someplace else. And so if they can actually manage the staff schedules, or at least know what those staff schedules are, they can then live the rest of their lives around the staff schedule. So I think that was a long-winded answer to your question.
No, that's great.
So, yeah.
That's great. Did either of the other two want to chip in anything?
Thank you, Tim. Yeah, and again, what Tim said, absolutely. absolutely came out because they said, just having that ability to have the name of my, homemaker that's going to come in and which days they're coming in and what's the, her name and even a phone number to call, or I get Meals on Wheels, but geez, now I got to be at the doctor and I'm not going to be here. I'm going to alert my Meals on Wheels. Don't meet me with the meal today because I won't be here. And I don't want you to get, because Meals on Wheels drivers are very good if someone's not there of alerting and saying, hey, they weren't there or whatever. So it's that whole coordination of care, and that is a real key what's going on here. The other is, when we talk about, and you talk about it in AAA, and we talk about, being able to improve, the transitions of care even back and forth from the hospital. Many times these clients will go to the ED and come back. Being able to have, for the RICO and the ACOs and those that take care of them, to have that information so they're not up, charging, having more tests or labs or whatever, run that they don't need because they've got that information right there at their fingertips. A lot of things happen from Friday night through Monday morning, and it's important to be able to get that information out. So that's it.
Great. Well, it doesn't look like we have any other participant questions. We have a couple extra minutes. Is there anything else that you had to cut from the presentation you wanted to talk about, or anything else you wanted to address before we sign off?
Well, I think, I talked about PHRs having a different flavor in the beginning, particularly related to long-term services supports. And I think, having that mixture of both the non-clinical and clinical data is, I think, where one of the major differences are. And part of that is, again, federally, we're now required that we have to put in place person-centered plans for clients for long-term services supports, particularly in the community. And one thing that I didn't mention and talked about was goals. So it's going to be important that the client be able to identify their particular goals and how they want to live independently in the community in the personal health record. And so when we look at long-term care, it's really because the goals are what's going to drive the services and supports that we provide. Typically in the traditional healthcare, it's the clinical outcomes or the what's happening clinically that's driving a lot of the decisions related to what care is provided. However, in long-term care, the clients are the experts on their lives, and they're the experts on their quality of life. And we really need them to be in the driver's seat when it comes to providing the services and supports that they need in order to live their lives independently. And so I think that's the different flavor we're talking about here, is that this can't just be a tool that pushes clinical information to the client. It has to give them also a sense of control over their services and supports. And that's the difference with LTSS, I think, that adds a little bit of a difference or a different nature of the PHR that we will be working towards nationally, is how does that work and how does that live and thrive or how does the client live and thrive in the community, and that they have this tool to support them to do that.
Great. Well, thank you, guys. I've just put up Pamela's contact information along with Danielle. So if you have any questions, I'm sure you can reach out to either Pamela or Danielle with those. And thank you, Pam, Danielle, Tim, for sharing the work that you're doing with us today. It's great to hear what's happening at the state level and what's going on with our Medicaid population. And thank you, everyone on the phone, for joining us. I hope it's been a valuable use of your time and that you're going to be able to use some of the information from today to further your own care transition efforts. Again, this webinar has been recorded, and it's going to be available on the HTC website within the next 24 to 48 hours. So thank you very much, and have a great day.